Jennifer Keys, thank you so much for taking time to talk to me about professional development. Now, of course, you represent the Division of Rural Hospital Medicine, which is a really important part of our wider profession. And so part of this chat is really getting your insights to what makes learning different, professional development different for our rural and hospital-based practitioners compared with more urban-based practitioners.
Several things probably. One is probably the most important thing, really easy access to money to use for your own education, which I think makes it very different from general practice. So it opens up a whole world of opportunities regarding being able to access things that are happening in Australia and the States and things like that. Number two would be the relatively procedural nature of quite a lot of the things that we do. So we actually need to, we do procedures which are infrequent but important to be able to do, and probably important to be able to practice. So the likes of intubation, chest drain, that kind of thing, ongoing requirement throughout your career, but you probably only get to do one chest drain a year, for example. So the procedural nature of some things would be one thing that's slightly different. And then the other thing I would think would be the team nature of rural hospital work compared to general practice. I appreciate primary care, a lot of it's team-based, but in a slightly different way, in that you and your team are responsible for the longitudinal care of a patient in general practice, but rural hospital medicine, it tends to be episodic care, sometimes episodic care over several days or a week, with multiple different doctors involved in each step, and that makes it much more difficult to tease out what your learning requirements are, whether your learning's been effective, and because it's difficult to tease out what went right and what went wrong in individual cases. It's not possible to measure. For example, in general practice, you can measure, say, on an equity basis, you could measure if just as a higher proportion of your Maori patients were on or had appropriately treated diabetes as non-Maori patients, but we can't do that.
I would imagine, though, there'll still be a lot of opportunity to reflect and think about the learning as you're going along. So what are your thoughts on the value of reflecting on one's learning? How does that play out?
Huge, really. And I would imagine, I know where I am, we're effectively a reflective group. So we have now a doctor's meeting once a week for a couple of hours, and within that we have two specific reflective practices, if you like. One is M&M and the other one is peer review. So we peer review cases and we look at cases where people died or things went wrong. So I think that is our reflection, and then I think often the learning is the learnings from those individual cases are often systemic learnings. They're not individual learnings. So I think maybe there's two different layers in that. Maybe there's a systemic learning, as in the system needs to change in this way to be able to not allow that to happen again. But there are also, for example, there were kind of several complaints around which seem to be probably communication based. So we're now going through a communication. We've got a communication professional coming in to do some work with us.
That sounds really great. So in that instance, you're taking one of the sort of the domains, if you like, of competence expected and sort of focusing on that as a development need. So do you often find that those peer review sessions give you insight to what your learning needs are? Is that one of the ways that you identify what you need to learn about?
It's interesting, isn't it? Because I think this, in some ways, the system needs to learn, and some way individuals need to learn. So I think probably as individuals, we tend to be looking for things that I think you pick up things when you see cases where something happens you're not particularly comfortable with, or, for example, over the last few years, I've been more involved in clinical management and also governance type stuff. And a lot of my learning over the last few years has been aimed at that, because I've identified that as my learning need. But from a systems point of view, that example about communication, but also sometimes it's not learning that you identify, it's just, let me try and think of an example. One example recently, which has been reviewed, and what was felt to be needed was, we have a VC system, a clinical VC system. So if somebody's very, very sick, we can have a ICU consultant on the end of a video in Dunedin. But perhaps what we needed in that case was an obstetrician on the end of the video in Dunedin. So it's not a learning need that's required, but it's a systemic need that's identified from our peer reviewer or M&M.
Just picking up on that point about the use of technology, do you think virtual networks and connecting with your peers in that regard is really useful for our rural practitioners?
Yeah. I mean, I always think that what I get out of CME, it's not just. I think when you're relatively young, what you think you get out of CME is facts. So it's all about still learning your trade, and it's all about knowing more about procedural sedation, or what to do with a difficult airway, or how do I manage diabetes better. It's all kind of very transactional, fact-based. And then I think as you get older, you start realising it's more about, I think some of the benefits of CME are not just the fact-based learning. For example, the risk course, I don't know if you're aware of that. So it's the Rural Interprofessional Simulation course, which happens in Ashburton, and it's run by 2 doctors that are joint emergency medicine, rural hospital medicine fellows. And it's team-based, so it's teams with 2 doctors, 3 nurses from individual rural hospitals. And it's simulated, and there's feedback about individual cases, but it's not feedback about the nuts and bolts of whether or not the IV fluid got put up too fast, or whether or not you should have done that procedure faster. It's about how do people communicate and how did people feel during that. So, for example, they'll teach the nurses how to respond when you know something's happening, and you see it, and you know the doctor is not seeing it. How do you escalate that? And they teach the nurses how to escalate that. Their thinking. So I think as you get older, you start realising, I think, a lot of your learning. And the other good thing about that course is it creates community in rural hospital medicine and within some rural GPs now. So, for example, we have a rural hospital we have a team from Ashburton, a team from Tikawiti, a team from Kaitaia, and a team from Queenstown. And that's what's creating community, I think, within rural hospitals.
So it sounds to me like rural practitioners are maybe geographically isolated in many respects, but they're certainly aware of not being professionally isolated.
Yeah.
And it sounds to me like you often engage in activities where you're working with others. Yeah. And I guess in clinical and non-clinical activities.
Yeah. And I think if you talk to the guys that started rural hospital medicine, they didn't even know the doctors in the next rural hospital. Whereas now I could talk about just about any rural hospital in the country, and I could tell you who the RHM fellows who are working there are. And
so peer activities and working with others is crucial, isn't it?
Yeah, it's crucial because it makes everybody, because we're doing a lot of things to try and bring people into rural medicine, but we have to try and retain them in rural medicine as well. And CME is, I think, an intrinsic part of that. And we talked earlier about the Rural Network Conference and the feeling that people get from it, that they're part of something bigger. And I think the Rural CME does that. We keep reconnecting with the same people, and we know that they're doing the same thing as us in a different small town. And I think we all feel part of something bigger. We all know it's necessary what we do. We all know it's quite hard what we do. And I think it helps retention of staff if people feel connected to what they're doing.
A couple of last questions, if you don't mind. One, I'm really interested in, how do you go about personally evaluating your learning? So we're at GP19 down here in lovely Dunedin, and there are a lot of great little sessions going on. So how are you going to determine if you've learned anything here and what impact that's going to have back with your patients and your wider team? What process do you go through?
I just have a process of mental soup. I don't have specifics. I find the whole process of identifying your learning needs and then deciding what you're going to do and then coming back to reflect it in a formal manner. I don't like it. I don't find it helpful. I think I do it anyway. And I think things are not as black and white as that, and things change throughout the year. And I don't think that's because I'm not reflecting and developing. It's just that I don't think I reflect and develop in the way that the system wants me to.
So how do you reflect and develop? Because
Soup. Mental soup.
So it's about,
It's just-
so for you, reflecting on your learning is about revisiting it and thinking about how that might apply to a situation in front of you, working through what you've learned in yourself, and rather than formalising it?
I don't know, Ken.
Yeah. That's all right.
I just know it happens, doesn't it? You read. I read an awful lot. I read an awful
Yes.
lot kind of online. I read papers, I read books, I read novels. I watch stuff, I talk to people, I talk to patients, and it all goes in there. And then I wake up one morning and I know this is what I'm going to do. And I go to board meetings and then I talk to people, and it all just, that's what I mean by mental soup. It just, and I think that's a much more natural way of doing things than actually having to write it down.
Not one linear process, but you draw on a whole lot of little pieces and naturally occurring times where you might.
Yeah, and then there's some kind of things that I write down on my personal development plan. Like I write down, I need to learn about governance. So this year I'm doing the company directors course. That's what will go down on my personal development plan this year, because that's a kind of thing that you can see and you can measure. And but I think the reality is that it's just not like that at all.
Great. So, last thing around professional development, what would be a message you would give to your DRHM fellows about the importance of engaging in learning? What would you say to them? What would you encourage them to do?
I think I would encourage them to engage in their teams and engage in their multidisciplinary teams. So I think doctors are much more enabled in terms of CPD than our nursing staff and our allied health staff. So engage in your bigger teams, and then I think engage in there's the self, and then there's the team, and then there's the bigger picture. And I think engage in the bigger picture as well.
Wonderful. Jennifer Keys from Division of Rural Hospital Medicine. Thank you very much for your time.
My pleasure.
Thank you.